So I'm Joff Swain, and it's really a pleasure to be here. And I thank you all for being here. And it's an honor, really, to kick this off. What I'm going to do is start sharing my PowerPoint screen right now, if I can figure out how to do this. And you should be seeing my PowerPoint now. I see a thumbs up. Thank you very much. That's super helpful. Um, So, uh, my task this afternoon to kick us off is to talk about the determinants of health and how they might relate to this Greater Watertown Health Equity Workshop and to faith leaders and people of faith more broadly. So I really appreciate that. Um, as Dan said, my bio is in your handout. I've got 45 minutes and I have about 60 minutes of content to squeeze into 45 minutes. So I'm going to do my best, and I'm going to actually trim off a couple more things because we're getting a little bit of a late start, and that is okay too. But basically, I'm going to talk a little bit about what determines health, a little bit more about chronic stress and how it affects people's health, and then touch briefly on what are the public health priorities for the local area in Watertown and Dodge and Jefferson counties. Now, I was going to ask someone to take the microphone around and have everybody introduce themselves and say their role in the community. But for the interest of time, what I would prefer to do right now, although I really don't prefer to, but nonetheless, I think we should skip that. But I want you to take just about 30 to 45 seconds here in silence and think to yourself, if it were up to you, what would be the one thing that you would proclaim as most important or most necessary for people to be healthy, either individual people or groups of people? Okay, so just let's take 30 seconds in silence and decide for yourself, if you had to write it down, what's the one thing? All right. Uh, Come to your own personal decision about where you would put your chips down if you had to put your chips down. And now we're going to talk about more about kind of what public health has to say about that question. I do want to add one more thing, which is that uh, in your handout, your hard copy handout that you have there, all my slide content is in that handout, but the order might be a little bit variable. So you may see me sort of skipping around a little bit, or more likely like taking only part of a slide at a time, but it's all there for your future reference. So, okay. And you've got my background, so I'm not going to spend any more really time on that, except to say that um, I've got 30 years experience in public health, and a lot of it has to do with community health assessment and community health improvement planning, and especially around social determinants of health. And we're going to spend a lot of time on social determinants of health today. And I'm going to even talk more about that term and some of these terms and what some of these terms mean and that sort of thing. But let's start with another term, which isn't always clear what we mean, and that's just the word health. So when I'm talking about health, I am thinking along the lines of the World Health Organization, affectionately known as the WHO, the World Health, WHO actually, the WHO, the World Health Organization, who says that health is a state of complete physical, social, and mental well-being, not merely the absence of disease or infirmity. Okay, so that's really important because that's the big picture of what we're talking about when we're talking about, can someone or can a group of people be more healthy? Now, it's also kind of hard to measure. So when my public health colleagues who are more in the field of measurement start to try to measure health, there's a whole bunch of ways to do it, but the most fundamental ways to do it are, how long do people live, and what's the quality of people's lives while they're alive? And It's actually not hard to measure longevity or life expectancy quantitatively. You can put a number on it, um, based on, any number of factors like how old you are now, where you were born, your gender, um, etc. And in fact, I've got some published papers on differences in life expectancy between different counties in Wisconsin, which is kind of fascinating. There's a very broad range, actually, of life expectancy by county in Wisconsin, or even by zip code within Milwaukee County, an even broader difference in life expectancy from one zip code to another. And we're going to talk more about like questions like why would your zip code of birth or zip code of residence affect your life expectancy? And we'll get into that. Quality of life is measured um, by asking people, what's the quality of your life? And so it's a survey or interview, and so it's a qualitative measure, but it's measurable nonetheless. And so we can tell in terms of health, we can measure it with these two basic measures of life expectancy and quality of life. So we can measure it at the individual level and we can measure it at the group level. Like I was talking about zip codes, or we can do it by race, or we can do it for age groups, or any number of things. And if we can do that, then we can also measure the differences in health outcomes across groups or between groups. And what that helps us understand is what these between group differences are, why they might be that way, and what we can do to try to minimize those differences. In other words, to maximize health for everybody. So now I want to talk, that was the term health. Now I want to talk about a couple other terms. And these are some terms that sometimes trip people up a little bit, especially over the last few years. They've health equity in particular, I think, has unfortunately become more of a politically charged term. And I want to just like clear the air on that. And let's just, in terms of today, here's how I use these terms. So first of all, you hear the word health disparity and you hear the word health inequity, and they seem like they should be synonymous, and in some ways they are, but there's some important differences I want to take a second to talk about. So a health disparity is any difference in health between groups of people. And when you say this word disparity, like, it's very objective and it doesn't get at what are the reasons behind the differences in health outcomes between groups of people. It just says, here's the difference, right? So an example, whereas health inequities, and I'll give some examples of differences in a second, but whereas health inequities, if a health inequity is a health disparity that is systemic or patterned or unfair or unjust or actionable, that means preventable, like you can do something about it. It's not random. It's not caused by the people who became ill. So let me give you some examples to make it more clear. So let's take breast cancer. You may or may not be aware, but actually men can get breast cancer. Men do get breast cancer very, very rarely. The incidence of breast cancer among men is very small, but it's not zero. Whereas breast cancer is much more common among women. So this is a health disparity. There's a gender-based health disparity in breast cancer rates between men and women. We normally don't think about it too much because most people understand this is a biologic phenomenon. It's not unfair or unjust. I mean, I guess you could say it is, but in the sense that there's no the only thing we can do to address that disparity is what we would try to do anyway, which is to reduce the rates of breast cancer among women. That's the thing. Whereas most health disparities are also health inequities. They're not biologic. They're not in your DNA. They have to do with the lived experience, the experience that people have in their lives that drives these differences. And so maybe the best example among many would be differences in infant mortality rates between people of color, so Black people and white people. So in Wisconsin, as in most of the country, the infant mortality rates for Blacks are 2 to 3, sometimes even 4 times higher than for whites. And it's also true for preterm birth. Actually, preterm birth is the number one driver of infant mortality. But it turns out this is not, unlike the breast cancer difference that I just mentioned, this is not a genetic difference. There's good, solid data to show. In fact, when Black women come, say, from Africa to the US as late teenagers or early young adults, but they're new here to the US, their infant mortality rates are almost identical to whites. But it's only once Black women have been here for a generation or two or three that we see these infant mortality rates start to worsen. So you have to understand, like, this is not a biologic difference. This is something that's systematic, it's patterned, and we should be able to figure out what we can do about it. That's just one example. So most of the time when I'm talking about health disparities, I'm talking about the ones that we should be able to do something about. That means I'm talking about health inequities. Now, health equity as a term, some people think, oh, okay, well, health equity means that we're at a place where we don't have any more health inequities. Um, that is actually fine as a theory, but it's probably not very practical. We're not likely to get there. But to me, this definition here by Paula Braveman of health equity, an environment where everyone has a fair and just opportunity to be healthy. This is what I think about when I think about health equity. And this is what I think is sort of a fundamental reason why we're gathered here today. Like, what is it that faith leaders and people of faith can do in Watertown, in Dodge and Jefferson County, in Wisconsin, to try to create an environment where everyone has a fair and just opportunity to be healthy? And actually, this gets to the actual definition of public health that the Institute of Medicine came up with really a long time ago now, about 20 years ago or so. Their definition is that public health is, now I'm quoting, public health is what we do collectively to assure the conditions in which people can be healthy. So that's what we're talking about here. So what determines health? At the beginning, I gave you 30 seconds to put your bets down on what you would say if you had to pick one thing. And I'd be really curious to take the time to hear what people thought, but we don't have that time right now. But I can tell you what most people think. What most people think determines health is two things. Do you behave yourself? That is, do you exercise? Do you eat right? Do you not smoke or do drugs? Do you wear sunscreen, your seatbelt, these kinds of things? Do you behave yourself? And do you go to the doctor? That's like our national myth about what determines health. And again, you can see at the top, health measured by length of life and quality of life, like I talked about before. So this is the story we tell ourselves, broadly speaking, in the US about what determines health. And it's an interesting story because it's about half correct, which means it's about half wrong. In other words, half of what determines health is missing from this story. And if we don't get at that part that's missing, then we aren't going to be able to improve health the way that we should be able to. And by the way, the US spends, I don't know, 2 to 3 times more per capita than the next most generous country, developed country in terms of healthcare. We really do have the best healthcare in the world, but we don't have the best health. Our life expectancy is something around 30th among all nations across the world. So our investment in healthcare, which is tremendously huge, does not give us the dividend that it ought to give us in terms of health outcomes, quality of life, and length of life. And that's because we don't invest in some of the other things that I'm about to talk about as much as some other countries do. And those other things are these social determinants of health, the conditions in which people are born and grow up and live and work and age. So these are things like education, employment, income, family and social support, community safety, transportation, the built environment, etc. And so I'm going to take a few minutes to talk about why. Why is it that these sort of vague things that seem so far away from the personal responsibility of behaving yourself and going to the doctor, why, how does it happen that these things drive health so strongly? At least half of what determines health. Maybe it's actually more. This is the UW County Health Rankings model. These numbers are approximate, but they're not far off. The research really shows that they're pretty close. So let me talk a little more about how do these things work. So first of all, it turns out that your social and economic status, your employment, your income, your education, they affect your access to care. So if you are a person who said, yeah, going to the doctor is the most important thing, well, if you are working in the gig economy, say, or you're working two part-time jobs and neither one of them has health insurance and you can't afford to get health insurance under the Affordable Care Act, or your state hasn't expanded Medicare or Medicaid, excuse me, or whatever, then you have less access to medical care. So these social and economic factors below are influencing your ability to more or less to access care. And unfortunately, they also influence the quality of care that you receive. That's a whole nother topic that we can spend more time on some other time. These same social and economic factors are also influencing health behavior. So we say in this country, individual responsibility, personal responsibility for behaviors. Yes, that's important. But the fact is that if you're working, say, 2 minimum wage jobs part-time and trying to pay your rent and feed your family, you're probably not going to be affording a gym membership. Whereas if you're say a retired medical school professor like me, you probably can afford a gym membership. You can probably afford to live in a place that's got more options for safe places to exercise. Food, by the way, healthy food is more expensive than unhealthy food. But once again, if you're in more the lower socioeconomic status group, then you're going to have a harder time eating healthy because it's more expensive to do it. And on it goes. Tobacco is more heavily advertised in lower income neighborhoods. Like, it's this very pervasive. So when we talk about health behaviors and clinical care, yes, they do matter. And what we also have to remember is how strongly they are influenced by all of these social and economic and environmental factors. But wait, there's more. So I just talked about the first two things on this slide about how social economic status affects access to and quality of healthcare and affects the likelihood of health behaviors. But the fact is that social and economic factors, social determinants of health, can also directly affect people's biology. An obvious example of this is toxic physical environments. So let's say you live in an apartment that has lead hazards. It's got lead in the plumbing or lead in the paint, or maybe there's asbestos there, or mold, or some code violations that make it more likely to have a fire. The smoke detectors aren't working. These are toxic physical environments that make it much more likely that the people living there will be less healthy, either as an individual, or if you think about like a neighborhood or a zip code where these toxic physical environments are more common. Now we're talking about large groups of people that have a lower likelihood of being healthy. So it's kind of obvious when you think about lead or asbestos that this is going to, quote unquote, get under people's skin and cause them to be less healthy. But what I want to spend most of the time talking about is the issue of chronic stress, which sometimes people term toxic stress. Those terms can be used interchangeably. Because stress hormones are probably some of the strongest and most common denominator mechanisms why people aren't healthy, or have not aren't healthy, but are less likely to be healthy. So I need to get into a little bit of biology here and talk specifically about two hormones, adrenaline and cortisol. And I need to talk about our sort of natural evolutionarily developed stress response, which we call fight or flight. So, if you can imagine living back in, in caves with Neanderthals or something, and the saber-toothed tiger, you're out for a walk and you see a saber-toothed tiger, like your stress response is going to kick in. Okay, there's plenty of analogs, in modern society, like I don't know, uh, you get in a car accident, your stress response kicks in and two hormones start flooding into your bloodstream. One of them is adrenaline. Adrenaline is there to increase your blood pressure and increase your heart rate. And in a stressful situation like a saber-toothed tiger or a car crash, probably, or any number of other situations, like you need that adrenaline. You need that because it's getting blood to your muscles, and your muscles need that blood in order to fight off whatever you need to fight off, or to run away, fight or flight. It's really important. And cortisol is there because what cortisol does is, in your body, there's places where we store energy. It's in a form called glycogen. And cortisol, when it gets into the bloodstream in large quantities, it converts that glycogen into glucose. And it floods your bloodstream with glucose. And you need that glucose because that's the fuel for your muscles. Fight or flight. You need the blood pressure, you need the heart rate, and you need the glucose. And it's the adrenaline and the cortisol that are getting you that, and getting you so that you can fight off the intruder, run to a safe space, whatever. And the idea is that after that stressful episode is all over and you're safely back at home, your stress levels go down, your cortisol and adrenaline levels go back to normal, your blood pressure goes back to normal, your blood sugar goes back to normal. Everything has worked just the way it should. And everybody has stress. And actually, some stress is good. But when you don't have the resources to manage or mitigate that stress, then it becomes a more chronically high stress. And it's stress all the time. It doesn't remit. So if you're stressed because you're worried about paying the rent or getting food for your family, or whether you're going to be evicted, or whether you're going to lose your job, or whether you're going to continue to be treated differently because of your skin color or your sexual orientation or whatever, when you're in these chronically stressful, this is not like, caveman days. This is modern society, and lots of people are under this chronic stress, and they're not usually not old white men that are straight and relatively well off. They're other groups of people, but anybody can be under chronic stress. But it's the chronic stress, the unremitting, unmitigated stress. That's also a situation where adrenaline and cortisol stay high. They never come down. And when adrenaline stays high, then blood pressure stays high. And if you're a doctor, you have a name for that. It's called hypertension. It's a disease. It's bad. It makes you more at risk for stroke and heart attacks and other problems. And if your cortisol stays high and never comes back down because you're under chronic stress, then your glucose stays high. And we've got a name for that too. That's called diabetes. And that's bad for all kind of reasons: kidneys, heart, brain, extremities, blood flow, all kind of stuff. And what's worse, cortisol also is a very potent immune system suppressant. So people with chronically high cortisol levels are at risk for immune system diseases like lupus or cancer or even infectious diseases. So toxic chronic stress is a real thing. It's the kind of maybe the primary way that these social and economic issues get under people's skin and make them more or less likely to be able to be healthy. Then there's a whole nother issue of epigenetics, which I don't have time to get into right now, but we be happy to talk with you about it some other time. But it gets at how some of the mechanisms by which these issues get passed along from generation to generation. So here's more like in the illustrated form, okay? So the point of this slide is it really actually doesn't matter what the chronic stress source is. I mean, it matters in terms of figuring out what to do about it, but inside the body, it all feels the same. If your issues are, I can't get transportation that I need, chronic stress, cortisol, adrenaline, under your skin. If your issue is, I have a lack of access to jobs or stores or services or housing that's stable or affordable, that's just getting under the skin in the same way. Cortisol and adrenaline, blood pressure and glucose, bad. If your stress chronically is coming from experiencing segregation or discrimination or a lack of sense of belonging, all driving under the skin, cortisol and adrenaline, the same thing. And I need to point out that these things, like, they stack up. You've got one, that's one level of cortisol and adrenaline. You've got two, that's a higher level. You've got three, that's an even higher level. They're piling up on top of each other. So I just want to say another word about this, because it's just really important to name that racism and other forms of discrimination are also piling up, right? So if you are a person of color or a person from some other marginalized community, an LGBTQ person or whatever, you're experiencing some form of discrimination, and you've also got housing issues, or you've also got employment issues or whatever, these are piling up onto each other. So in the interest of keeping moving along, I'm going to skip these next two slides. They're in your handout. I encourage you to read them. I would have been talking here about unconscious bias. I think it's really important for all of us to be very aware. Like, I try very hard, to be an anti-racist person, but I'm also aware that my unconscious is racist. It's unfortunately the truth of it, and it's sexist, and it's ageist, and it's all kind of things that I don't like. But if I'm not aware of how that affects me, then it's hard for me to manage. This is what I would have talked more about, but I encourage you to do some looking into it yourself, and I'll provide you some resources at the end where you can look for more information on this. There we go. So now I'm going to shift gears, having laid the foundation there, and just talk briefly about some of the local public health priorities right here in Watertown and in Jefferson and Dodge County. So I can't see y'all, but if you just like raise your hand and maybe somebody with a microphone can give me a sense of the proportion in the room. How many of you were involved in providing any sort of input into either a community health assessment or a community health improvement plan for Watertown or for Dodge and Jefferson County?
Maybe about 5 of us, Jeff.
5 out of what, 15 to 20?
5 out of about 25.
5 out of 25. Okay. All right. Well, then we have more to talk about. So a community health assessment and a community health improvement plan, or sometimes known as a community health needs assessment, it's a little complicated because there's some requirements for local health departments to do this every 5 years, and there's requirements for hospitals and healthcare systems to do it every 3 years. But in Watertown and Dodge and Jefferson County, they're typically done every 3 years. And they're done as a partnership between all of your local health departments. So that's the Watertown Health Department and Dodge and Jefferson County Health Departments, and my apologies if I'm missing any others, together with your local regional hospitals and medical centers. And the way these work is they look very deeply at demographic data of the population. They do surveys They do focus groups and key informant interviews. They pull all this information together. They develop some prioritized recommendations around like what are the priority issues, and then around what's the plan to address those issues. So I guess the first thing I would say here is that if only about a quarter of you have had any involvement in this time around, the current version right now for Watertown, Washington, why do I keep saying that? Watertown, Dodge, and Jefferson County is the 2022 through 2025 plan. So sometime around a year or so from now, your local public health and healthcare leaders are going to be starting their process for developing the next 3-year plan. Y'all ought to be involved in that. All of you ought to be involved in that somehow, some way, either giving input or being part of developing the prioritization process. So let me just give you a couple of quick examples of what's included. And we'll start with demographic data. This is just one example. There's just and I've got the link at the end in the resources for the full assessment and plan documents. I mean, it's well over 100 pages. So this is just a tiny, tiny fraction. But one example of demographic data that is in your current health plan has to do with local inequities in child poverty. So child poverty is a very important driver of health for children and for them later on when they become adults. And child poverty is especially, I think, a compelling issue because it's very clear that children are not poor because they're lazy or through any fault of their own. It's not a child's fault that they're living in poverty, right? But it's a very, very strong driver of their current and future health. And in Dodge and Jefferson counties, about 8 to 9% of white children are living in poverty, below the poverty line. And so that's between 1 in 11 and 1 in 12 kids. That's a lot, actually. That is not a small number. That's for the strong effects that child poverty has on health, that's actually a large number. And yet, compare it to what you see for the Hispanic population in Dodge and Jefferson County, about 2 or 3 times higher, right? So now you can start to see just one of many, many drivers that are in your current health plan locally that illustrate why Dodge and Jefferson County and Watertown are not as healthy as they could be, not as healthy as they should be, and why there are some health inequities, differences in health between groups that are bigger than they need to be. Let's put it that way, or that wouldn't need to be at all in an ideal world. So in addition to the demographic data, I said there's surveys. So one of the parts of the survey was to present a series of issues. I've just listed a few of them here, not all of them. And basically the survey respondents were asked, do you think whatever this thing is, do you think it's a strength here in Watertown and Dodge and Jefferson County? Do you think it's a weakness? Are you sort of, I don't really know, too hard to say. And so I just want to highlight a couple of these things. So like the criminal legal system is actually another one of these social determinants of health. And among the respondents to the survey, 8% said that's a strength here in this local area. And about twice as many said it's a weakness. And there's this ginormous group here who were like, I don't know. I can't say. I can't. I just don't know. Whereas for transportation, a lot more people had an opinion, and about 10% said, or 11 said, this is a strength here, but nearly half said it's a weakness. Transportation options are a weakness here locally. For income and wages, 15%, the strengths are getting a little more here, said it's a strength, but 40%, almost 3 times as many, said that's a weakness here. Job options, a little more even, but still a quarter to a third of people are saying that's a weakness here. Education opportunities turned out to be probably sort of the bright spot. About 38% perceive that as a strength, compared to only 16% perceiving that as a weakness in the local area. A few more people said safe places to be active and sidewalks and bike lanes and stuff like that was a strength. But notice a quarter say, no, actually, it's in my experience, that's not the case, right? So this is more information. Again, it's just one, that's a very long survey. So this is just one little tiny part of it. But to give you an example of the kind of data that the people who are trying to prioritize what to do to improve health in the local area, what data are they looking at? And then focus groups. Focus groups are super important because you could start to really dig into what's going on. What are people thinking? What's under the thing that they're talking about now, and what's under that? And I don't have to read all of these things to you. It's in your handout. But now I think you can see just by glancing at this list of themes, and there were a lot more. I admittedly I cherry picked from the theme list in the online document. And I think you can see that a lot of the stuff that I was talking about a few minutes ago are things that people actually say. So when you ask people in the abstract what drives health, people will answer it's individual health behaviors and it's medical care. But when you start talking to people about their lives and what's stressful in their lives and what is kind of getting on their nerves and making things hard and therefore making it an issue for health, people will identify these things. And in Watertown and Dodge and Jefferson County, they have identified these things in these focus groups. So as I said, you can see your full 100+ page needs assessment and the implementation plan at this link here. But basically there are 3 or 4, depending on how you count them, local health priorities that your public health and healthcare leaders have identified based on the results of all this input. And they are affordable, quality mental health care, affordable, quality housing, and affordable, reliable transportation. Those got lumped together, but nonetheless, and affordable, quality childcare. And then they made another statement that's really important, an overarching statement about the equitability of access to these things. So it's not just that Watertown and Dodge and Jefferson County need more of this and more of this and more of this and more of this, but it needs to be available more equitably. They need to be available more equitably to everyone. So this is like the official position of the public health and healthcare leaders in the local area. So now the question is, like, if you, assuming that you may agree with this, the question in my mind then becomes, okay, what can faith leaders and people of faith do to help advance these priorities? So this is my summary slide. Again, you've got it in your handout. I'm not going to reread it in the interest of time, but just the point being that the things that have been identified in Watertown, Dodge, and Jefferson counties really align with what we know about the science of what causes health for individuals and for large groups of people. So the addressing these issues is really important. So let's see, what do we have in terms of time? I think I am right about at 45 minutes.
We've got
Reverend,
about 5 minutes.
so do you want to take us a couple minutes, maybe, and get 1 or 2 or 3 people to just give some brief general reactions and some initial thoughts maybe about how faith leaders and people of faith can in Watertown can work to improve health by addressing these root causes? Maybe just a couple of folks' opinion.
Well, let's see if anyone has something to say. Sue?
With the ministry that John and I have with running the House of Peace, we address all 3 of these issues: the mental health, the child care, the housing. And we work with the landlords to get the marginalized individuals into the apartments, but it's contacting the landlords and building a relationship with them so that he can trust us enough to rent to the single mothers who we help. And I think if we all work together to help the single mothers, our children will not be at risk.
Josh, that was Sue Trepty, and she runs House of Peace, which provides, if I understand it right, housing for, yeah, right. All right.
Good afternoon, Jeff. This is Carol Quest. Nice to see you. Welcome to our community virtually. So I am very active in the community health assessment and the improvement planning through my position in the public health department in Watertown. And I invite all of you to connect with your local health department to be more active. We currently have 2 very active work groups. One is addressing mental health and the other is working on solutions to transportation across the 2-county area. We need your voice. We need your expertise, your reach. We, in public health, we work collaboratively, and it is a big lift, these priorities that we've established, but we can make a difference working together. So I appreciate this opportunity here today, but it is important as we continue to on this journey, as we update our health assessment. Like Jeff said, we will be engaging in an update in 25. So your voice, you'll have many opportunities to participate and then continue to participate in the health improvement planning. Thank you. Oh, okay.
Carol, if it's all right, I'll put your contact information in our follow-up email. So if people want to participate, they can. Katie, did you want to say something? All right, I think that's it. I guess we have, Josh is muted here. I guess we have just a couple minutes for quick questions, if you need clarification on anything. Yeah, your sound went away.
Okay, can you hear me now?
There you go.
Okay, sorry about that. So I really appreciate those comments, and thank you, Carol, in particular. I encourage all of you to take Carol up on that offer, because I mean, I've been working for several years with faith leaders in terms of the question of how can people of faith work more closely together with public health folks, because we need each other. So let me just go back quickly here to my PowerPoint and just sum up very quickly. I just want to make a segue to our next speakers who are talking about narrative. And my point here is that there are values that underlie this work, and these values should be very familiar to people of faith, right? Everyone deserves respect and dignity. Everyone deserves a fair shot at thriving, and we're not the kind of people who leave people behind. So these are from the Governor's Health Equity Council and the UW Population Health Institute. I'm sure Angela and Jed are going to say more about it, but I'm just trying to make the transition. Like, the moral underpinning of what I'm talking about is here, and it's all cohesive with the work of people of faith. I also encourage you to, if you are interested, review this document, the Foundational Practices for Health Equity, which has a lot more to say about what individual organizations can do and what's important for advancing health equity. And in your handout, you have these resources, including for your community health assessment, including this one, Bias Habit and Project Implicit, talking much more about unconscious bias. And the foundational practices for health equity you can find here at the Wisconsin Center for Health Equity website. So that is it. I thank you very, very much. It's just been an honor to be here, and I will turn it back over.
So again, I'm Angela Acker, she, her. No, Reverend Dan, I'm not a doctor. I wish, but no, maybe in my heart. And so I am the Narrative Infrastructure Team Lead at UW Population Health Institute, County Health Rankings and Roadmaps, and also representing our wonderful project, Narratives for Health. And joining me today is Jed. Jed, go ahead and say hi.
Hey folks, I'm John Morrow, the Narrative Infrastructure Specialist over at County Health Rankings and Roadmaps, and blessed on this Sunday to get to work with Angela, doctor or otherwise, and get to share with you all some of the work that we do and that you all do, even if you don't know it yet.
Awesome. And everybody can hear us well. We're clear. Okay, awesome. Well, thank you again so much for inviting us today to share with you about the power of narrative and using narrative as a tool in your work, especially as faith-based leaders and communities. I know all too well, growing up as a preacher's kid, that our faith systems can help us make meaning of the world around us and give us hope for things unseen. And this is why I enjoy working with Faithful Action for Healthy Wisconsin. And I'm excited to be here with you virtually today, so you can see the connection between narrative and how you can use that as a tool with your faith communities to advocate for health and a better, thriving world. And just to note, our work through Narratives for Health, which is a collaboration between us at County Health Rankings and Roadmaps and Human Impact Partners, is funded by Robert Wood Johnson Foundation and Centers for Disease Control and Prevention. The views expressed here do not necessarily reflect the views of the funders, but as I like to say, thank you so much for your money. And with that, I'm excited to turn to our content. So today we're going to provide an introduction to narrative strategy for health equity. We're going to discuss dominant narratives versus transformative narratives, what that even means, explore ways to apply narrative to your work, and review the project. And so on this next slide, you'll see that the problem that is occurring with us is that dominant narratives limit our ability to advance deep health equity. And Jeff did an amazing job setting us up around social determinants of health. And also to reiterate, another definition of health equity that I hold dear is by Dr. Camara Jones, the insurance of the conditions for optimal health for all people. Achieving health equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustice, and providing resources according to need. For all communities to thrive, we must build our own narrative power to transform what we think is possible and make necessary change and necessary structural changes. Changing the rules, whether they're written or unwritten, on what society can do and what society can be. And so our goals for the project are to shift dominant narratives by building transformative narratives. They're to support and develop a diffusion, a spread of shared transformative narratives, and then also to develop and strengthen relationships with those in the health equity space and those that are touched by health equity to build internal capacity and impact. To work toward these goals, we at University of Wisconsin Population Health Institute co-lead Narratives for Health with Human Impact Partners, as I've stated before, but it's alongside a myriad of partners, which we'll share later on in this presentation. And so what guides this work is advancing racial justice and health equity. We want to build community and we want to work collectively, whether it's the grassroots or the grass tops or anywhere in between. We raise consciousness about society problems, share grievances, and power in terms of who is responsible, who can confront them. And we center this around hope, creating hope as an action by collectively describing the way we think the world should work and helping each other integrate that into all that we do. And we'll go further into what we've done with Narratives for Health. But first, we'll talk to you more about narrative, and Jed will begin that for us.
Thank you, Angela. So yeah, what do we mean when we talk about narrative? And importantly, for you all, why does that matter? So we use this definition that narratives are the values-based meta-stories, or the themes of the stories that we tell, that determine how we interpret reality all around us, about how and why the world works. And these narratives have the ability to shape public consciousness, which is to say, how we think about the world, including our collective sense of responsibility and possibility. So what can we do and who is responsible for making those changes? So this quote by James Baldwin encapsulates why shifting how people see and understand the world, reality, is also the root of enacting change. And that is, the world changes according to the way people see it. And if you can alter, even by a millimeter, the way people look at reality, then you can change.
Of health and really understanding how our health and our behaviors are often dictated by the conditions that are set before us. But even going one step further, we can think about how those conditions are set based on decisions that are made and through the shaping of that which is power. And narratives are a form of power. Martin Luther King Jr. said, "Power is the ability to achieve a purpose. Whether or not it is good or bad depends on the purpose." And we know that advancing health equity means rebalancing of that power. And so Grassroots Power Project has a framework that defines 3 dimensions of power. And I'll walk through those relatively quickly, but I think we gave you a handout and we'll show you our website and where to go to learn a little bit more about that. So Grassroots Power Project, they changed their name recently, and it's still something of a roll of a tongue. But so the first definition of power is the most visible. It is about the power to organize people and resources to influence decisions. It's the power to win a change we seek, to pass a policy, win an election or initiative, and then also thinking through like most campaigns, organizing, and electoral work we see today are focused on this first dimension of power. And I heard Sue, I think that was the name, mention an example that fits firmly within this of, I think it was houses of peace, of thinking through how to organize yourselves to then bring trust to the landowners, to then um, shift that power over and give housing rights to single mothers. So that is a way to organize people and your resources to make a change. So just wanted to lift that up. The second dimension of power is often hidden. It is the power to set an agenda. The second dimension of power is about the power and infrastructure to influence what's on the decision-making table and the political agenda. So think about your community health needs improvement, your community health needs improvement plan, um, your community health needs assessment, and think about how those things can help set an agenda. Think about the city council hearing or attend any public meeting that you have. Those are examples of this particular face of power. And just think about how anytime you go into a public meeting, there are always issues that have been prioritized, that table has been set and that agenda has been set. But how can you change what's on the menu and provide a flavor and variety that fits your community needs? And then we have the third dimension of power that will be highlighted by the magic of Jed running our slides. And this is the invisible face of power to influence worldview or ideology to shape what is possible. The power to change and hold public narratives. This is where the beauty comes in, and this is why I love my project so much. We don't even know it's influencing us. Um, and we don't even know that it is influencing the way that we think. This is about shaping people's conscious and unconscious understanding of the world. And this is also thinking through the form of power that shapes how we make meaning of the world and our place in it. And it shapes our lives and how the world works. These powerful public narratives become a kind of common sense that orders the information and data and facts we encounter and becomes the filter through which we incorporate them in our minds. And it filters what can blind us to some things. It can foreground and background others. Work on this form of power is long term. And these things that we can do in this realm include defining and reinforcing key themes and values that bridge the issues on our agenda, what is meant by fair and optimal living conditions, systems, processes, who has the right to be healthy, who has the right to have opportunity, what is the role of government in achieving this. And we can name and activate key values and beliefs to shape public debate, and we can challenge the current dominant worldviews and narratives. And this is a form of power that we and those we work with already have. If we want to actually overcome power imbalances and share and build power with those who are facing inequities, which again is directly connected with overcoming structural racism and oppression, we have to also explicitly work on shifting power along these dimensions. And these forms of power are interrelated, so they don't just stand alone, they work in tandem together. Transformation requires progress on all three dimensions of power. And so let's go into more about how narrative is situated. Narratives are invisible, as we mentioned earlier, in thinking through the relationship between narrative and power. Narratives are all around us, and they influence what we can do and shape our decisions. In that sense, they are like the air we breathe, or in this model, we like to share an ocean we swim in. So put on your snorkels and swim with me a little bit. The deepest part of the ocean, or our thinking, is at the level of our values and worldviews. These form the basis of our narratives in which are expressed through the meta stories we tell. The narratives are the themes of those stories, and narratives are then communicated through messages and the stories. The underlying narrative acts as the frames or lens which we communicate the messages and stories. And the narratives then are translated into specific messages. Narrative is also the product that you may or may not necessarily drop into a press release, but you can. But most importantly, it is the underlying set of values and worldview that informs how you write your press release, as well as other products and communications. But most importantly, it undergirds what we do. So it informs our strategy, the culture we set, who we partner with, how this contributes to a movement, what we advocate for, and how. People are operating on narratives every day, whether you like it or not, they're there. And so this is just an opportunity to actively change the narrative from the status quo to the different narrative that supports health and social justice. So the first step in narrative work is identifying dominant narratives. Dominant narratives are those held by many people at a moment in time, and they are omnipresent or insidious. So they guide our thoughts and actions without us even being aware of them. They are embedded in our institutions, structures, norms, policies, systems, laws, and culture. And so this morning I was listening to Dr. Kia Conroy. She's the pastor of We Make Wells. This morning, she was coming up on my Facebook screen for some reason. And in her message around the Israelites being stuck in the wilderness for 40 years after being delivered from slavery, they complained and wanted to turn back. And so she said something very profound in her statement. We can love systems defined to break us only because they are consistent. And that hit me because I'm like, dominant narratives are consistent. Importantly, dominant narratives are created. They are not naturally occurring or innate. Dominant narratives are drawn from and they perpetuate the values and beliefs of those in power and our reigning social structure. These dominant narratives limit progressive change and limit the solutions we are considering. An alternative narrative opens up the possibilities of many other solutions. And when it comes to emotional impact for people, they are more powerful than facts. And the past 7 or so years have shown us that in alarming ways. And so over the last 40, 50 years or so, a set of narratives based on what we call the neoliberal worldview have become dominant. And those show a purpose to wanting people to think this way, to divide us, to benefit a small number of powerful elites and hurt many people. And some current dominant narratives are individualism, racism and patriarchy, anti-government, free market. Um, to explain just a couple of those, and then I know we have a handout that you can really deep dive into each of these. But for example, individualism um, is and reflects that we're all on our own and that the collective society has no role to play. This message of we usually hear, pull yourself up by your bootstraps, but think about who actually has the bootstraps that they can pull up. Think about who has maybe no laces on their boots. Think about who doesn't even have boots to begin with. Think about those who have been centuries of steps ahead of the rest, and how that dominant narrative doesn't really hold true when you really peel it back. And you can also think about the role of things like free market or the narrative that the free market is inherently efficient. Competition and choice provide the appropriate and natural way to judge and reward winners. There's winners and losers in the society. That the free market will take care of all of our problems, that we should exchange our health, labor, and planet for economic growth. And so all of these dominant narratives are all tied together with narratives that center and support racism and white supremacy, patriarchy, and other systems of oppression, including classism, ableism, and all to divide us and not bring us together. This just means that we have to offer an alternative, more transformative narrative that fights back against those dominant narratives to get to our narrative that can be more broadly held and felt. We really need to cut across our public health policies, initiatives, campaigns, research, data, programs, how we think health is created, like Joff was mentioning earlier. This worldview should signal implicit understanding of what we all deserve, what is allowable, what government's role is in protecting us, who is worthy of health, and what we value. And thinking about the conversations of democracy, and they're only going to ramp up even more in 2024, we need to get beyond big and small government and get to what we want government and society to do, because those are just tools to get us to respond to our collective will. So imagine what could happen if we actually have government structures and systems that are about people's well-being and not about control and profit. What happens when we also tackle structural racism, anti-Blackness, and create spaces where we call in a larger we without exclusion? And imagine the world that would be far more beautiful because of it. So we're all here today because we believe we can change dominant narratives, especially if we create a larger infrastructure of people who are working toward in a focused, organized way to make dominant narratives visible, and so they lose their power, lifts up a different set of values and beliefs embedded in a transformed narrative and change what is possible. And with that, I'll shift it over to Jed to talk about a few examples of what that looks like.
All right, thank you again, Angela. So yeah, what does this look like when we apply these ideas of dominant and transformative narratives and take this way of thinking into public health and health equity work? Well, here at UWPHI, the Match Group, our sort of sister program, organized a project called the Healthy State Initiative. And members from that work were convened statewide with the support of our partners, human impact partners, to identify key toxic themes in dominant health and health equity narratives in Wisconsin. And in those conversations, a few came out over and over again. Things like Angela has discussed, right? Ideas about the free market, about individual responsibility solely, that it's a zero-sum game. Somebody has to win, and somebody has to lose. That we're powerless, and others as well. And those toxic themes, those narratives, gave way to a certain set of public health messages. Things like during the COVID-19 pandemic, that a decision to wear a mask or get vaccinated only impacts the person making that decision. That businesses will do what is best for their employees. And other messages that really didn't center our collective well-being, because they led to policies and practices, as those ideas were repeated and repeated, that didn't help communities. It required individuals to find their own PPE. It didn't create any protections for those essential workers who couldn't work remote, who couldn't take time off. And it blamed people who were working day in, day out for all of our problems, right? So those toxic themes led toxic messages and were expressed in toxic policies and practices. So coming back to the drawing board, the Healthiest State Initiative, that work group, started brainstorming, well, what are transformative narratives? What are those themes that, if we talked about things like this, would lead to better outcomes, healthier communities, and would keep us all safe, right? And they were things like everyone has inherent worth as a human being, that we care for one another, that we have enough in terms of resources to do that, to take care of one another, that we value the process and how we come to decisions just as much as we care about the outcomes. And we want to include everyone in that decision making so that everyone has a just opportunity to be healthy. And themes like that led to messages like these, that every Wisconsinite should have what they need to be healthy and safe, that we can respond with measures to support our health and the economy so that we're better off. It's not a zero-sum game of we have to sacrifice one for the other to do better. And at the bedrock of it all, that we all do better when we all do better. So with those themes, those values and messages in hand, they advocated for policies and practices that look like this. Keeping people safely in their homes, right? Providing people with personal protective equipment. Policies that made sure that we took care of those who were at the highest risk, right? Those who are on the older side or who can't afford their own health care, right? So by taking that step back and instead of, fighting every fire of trying to address the concern of every toxic message, what they did was they went back and listened to one another. And by coming out with a set of values that they cared about and that their communities cared about, they were able to have a coherent set of policies and practices that they wanted to work towards to keep everybody safe. And we have another example here that Angela talked over.
Awesome. And I just want to do a time check. Showcasing right now. Yes, they're from like health departments or collaborations that center like public health, but these are also examples that you can relate back into your faith-based communities as well. So just think about it as like what narratives are being highlighted, what messages come out of that, what actions come out of that. And so the Minnesota Health Department, Department of Health, has been doing narrative for a number of years. They're actually one of our advisors, which is great to have. And so this shows a nice example of how narrative can change your work and your messaging. And so MDH, or Minnesota Department of Health, was working on the determinant of health of wages. And so the place of many of us in public health, we might start with messages like, increasing minimum wage will allow people to buy healthier food for themselves and their families, reducing future healthcare costs. Um, but then we're always equating our lives monetarily. We're always putting a price tag on a life. And that is definitely reinforcing a dominant narrative that health comes from healthy behaviors. That's one dominant narrative. But then also that we shouldn't be most concerned with healthcare cost. Next slide. And so starting with elements from their transformative narrative, like we share responsibility to create the conditions in which everyone can be healthy. They developed a very different set of messages. For example, livable wages make good citizens, able to create healthy, thriving communities that contribute to the good of the whole state. And so this is a nice example. It's not a perfect example. As you heard, I mentioned good citizens, but that's a nuance there around citizenship and whether or not there should be value between, who is a citizen versus a resident. And as we know, everyone deserves great health. Everyone deserves to thrive regardless of their citizenship. But it also shows a okay example of shifting away from individualism and healthy behaviors, um, and thinking about your health as far as slowly healthcare costs and shifting it to more transformative understanding, that everyone should, be able to create a healthy, thriving community, and everyone can contribute to the good of the whole state. So I'll shift it over to Jed again to talk a little bit about our project.
All right, thank you again, Angela. Yeah, and so unpacking these dominant narratives and lifting up our own values, and the values of our communities is why we began the work of Narratives for Health, this project. And we know that building narrative infrastructure takes time, relationships, support for one another, and also hope and bravery. We put a lot of our emotion and our values into this work, and I feel very lucky to be able to do so. But in order to be able to shift to a place where we and our partners can work collectively and organize around these uh, actions, we do a few different things. We provide discussions and trainings like this one, as well as things that are a little bit more in depth than just this 1 hour overview, that you can bring back to your organizations and your communities and partners. After going through trainings like that, we offer continued support because this takes time. Like I said, you aren't going to, change mindsets overnight. And that's all right, but we're very aware of that and we try and support the folks who are doing this work. Um, through funding opportunities and just a space, a community of practice to be able to continue to engage and learn from one another. We do evaluation and research, of course. We're a university, so we're always checking in to see where things are landing and how things are being taken and where we can improve and make this more seamless and more effective. So that we can continually develop and evolve this program and content from what we focus on to really what folks need at the end of the day. So as Angela mentioned, with our Minnesota example and the example that I talked about, Healthy State Initiative, we place a particular emphasis in this work on centering hope in our shared values through shared transformative narratives. So that process of creating a shared transformative narrative is a great way to build relationships and to get aligned within your organization and with your partners. And as you can see from this slide, um, we have a sort of step-by-step way that you can sort of have these conversations with one another and go from finding a group of people that you want to work with for a particular issue or action, maybe, and to building relationships and building trust, because all of this work only ever moves at the speed of trust, so that you can share stories and what values animate you and bring you into this work, right? Why are you called to this work? And in doing that, you can create a shared understanding of narrative, both the dominant narratives that stand in the way of where you want your communities to be and what they deserve, um, and also starting to build a transformative set of narratives that can help guide your work, right? So that in every action that you take, you are consistently showing up with that message. So things like Jeff mentioned in his presentation, right? That we all do better when we all do better, and that we all take each other along, right? We don't leave anybody behind in our communities. And after developing those messages, you find ways then to truly apply them in your day-to-day work every day, in conversations, in sermons, in advocacy, etc. So in addition to our transformative narrative, um, we also, at this point, have engaged a network of over 1,000 people in the last few years that we've been doing this work, all across the country who have been through these narrative cohorts and who continue to remain in relationship with one another, continuing to learn to celebrate wins and to figure out ways to work around challenges. But I'll pass it back to Angela to showcase a little bit of the work that we've done around transformative narrative and developing that for our own work.
Yeah, we just want to give you a taste of a little bit of the handout that we share with you to preview that health equity transformative narrative. And so that draft was developed in the first couple of rounds of our project, which began in 2021. We, alongside our partners, created this draft, and I like to emphasize draft a million times for you to understand this is not like a static or final messaging document, but it is a collective narrative that will continue to grow and evolve and change. But it is designed to ground our work so that we can then begin to operationalize it and operationalize the shared narratives and values that uplift health equity and get us to the world that we want. And it begins to contrast our values and beliefs with those that are dominant. And hopefully one day we'll look, years past and say that now we have a new dominant narrative that reflects a thriving world and the world that we want. So this is not intended to be like a public document, but it is a working document that reflects our worldviews, and it serves as a tool so we can think about how to frame our issues to our audiences and even change the way we work. And so this isn't at the level of focusing on like specific policy demands, but it's again the values that would create the foundation for those policies. And so again, you should have a copy of the full transformative narrative for you. You'll find that transformative narrative and the key narrative statements that emphasize a value we want to uphold with a fuller description of that statement. And I'll just preview just a couple of statements to give you a taste of the beauty that I find within this document. And so on the next slide, you see that one of the narrative statements that we uplift is healing is interconnected, which you as, faith-based community members should really hold that dear. Healing is definitely an interconnection. We take care of each other because we all do better when we all do better. We make sure everyone has what we need to be at ease, not just physically, but also mentally and spiritually, because love, joy, belonging, and creativity are basic needs. Our well-being is also connected to the health of the planet and the other living things and beings who share it with us. And then on the next slide, you see another statement. We can organize a world where everyone thrives. And on the next slide, you see we can dismantle systems of oppression and heal our wounds. That's my favorite. And this is the last one I'll share. We can transform and we can have the power to transform the future. Change is natural and necessary. Through organized collective action, acting out of love, not fear, we have the power to build a transformed future in which everyone can thrive. So you can peel back and go through that transformative narrative. You can see what statements really resonate with you. But then I urge you to look at that and see how can you then use those narrative statements to create messages, to create actions, to change how you work. And I'll shift it back over to Jed.
All right. Thank you, Angela, for sharing that. And absolutely, just like she said, I encourage you to take time. It's a Sunday, right? So take time and really read through those statements and give them a good think about how they land with you, how they make you feel, and where the work you're already doing and the work that you could be doing is aligned with some of those things that we've come up with together in conversations all across the country over the years. So, how do you use documents like this, our shared health equity transformative narrative, or any other transformative narrative that you come up with your partners, right? Well, as we've been saying, in order to shift dominant narratives, we need to create alternative, transformative narratives that can frame a different way of understanding and looking at the world, a different way of understanding what the solutions to our problems might be, and who's responsible. So, in the work that we do, we provide key examples across a few different buckets here. So, for us in public health work, data and evaluation and research can be guided by these new narratives, communications and messaging, policy development and advocacy. So especially here, I think, as members of your community, responsive to the needs of your community, um, you know best the issues that you all confront, right? And something like a transformative narrative statement being grounded in values and your own experiences can help powerfully guide advocacy work that you all do. And also relationship development and what we call creating a container, but really just means creating the spaces for all of us to be heard and to listen to one another and to work together, right? And the last bucket that we call out is strategic and program planning. So just like Jeff mentioned, just like was mentioned earlier, Catherine, I think, right, in the process of community health needs assessment planning and all of the work that public health department does in relationship with your community. That's a chance for you all to make your needs, the needs of your communities heard in that process, and make sure that lives in a document that will be referred to over and over and over again in years to come, as funding is sought and secured, as programs are planned and carried out. In all of those ways, you can take the values that you believe in and the issues that you confront and bring them to these decision-making spaces. And you'll find more in-depth examples of all of those buckets, all of those categories in the hand that we provided. So in our own work, from that network of over 1,000 people that we've engaged with at this point, we see a lot of different ways that these transformative narratives are being used in strategic planning, in facilitating cohorts, so doing this sort of training and taking it to other partners and other communities and other stakeholders. Developing other training and coursework where this sort of fits in and can help complement other ideas, right? Because the work of narrative doesn't stand on its own. It is integrated into everything we do. Absolutely. Including into folks' communications and messaging and reports and things of that nature. And also for those who present in conferences, presenting on this work in conversation and in presentations at conferences. We see folks use this in their own equity, diversity, and inclusion work because there's a clear overlap between the work of uplifting narratives that include all of us, that say that we all do better when we all do better, and the work of equity and inclusion. As well as presentations, policy recommendations, data and evaluation. And this one feels sort of the least academic of the bunch of them, but I think in a very real sense is definitely one of the most important. Just talking about this with other folks, I think that sort of learning how dominant narratives work and realizing that you get a choice in what kind of narratives you want to put out in the world based on your values or based on the values of others really changes the way you think and changes the way that you talk about different issues and day-to-day life with other folks. And that's no small thing. Going back to that quote from James Baldwin, right? If you can change the way you see the world, even by a millimeter. So this work is still only in the beginning stages. We're years in and just at the starting line. So we're grateful to all of the staff, all of our partners and advisors, and most importantly to the 1,000+ people, the narrative builders, who've been engaged and involved in this work to really change the world and change the way that we see it and understand it one narrative at a time. And you can see all of our different partners from over the years who have done really great work in bringing this to their own communities. So thank you all so much for engaging with us and learning more about Narratives for Health. If you want to learn more, absolutely go check us out. We're now website official over on County Health Rankings, which is true as of just this past week. So a well-timed workshop meant to be for you all for sure. And we look forward to continuing to stay engaged and hope this was useful too. And we're grateful to share this all with you. So if you have any questions or want to bring this into your own work or just dive deeper, feel free to reach out to us via email, narrativesforhealth@chrr.wisc.edu. And again, you can learn more at our website or right there. You can Google us now, and that's pretty neat, I think. So still riding high on that one. But in partnership, I'm Jen Morrow and Angela.
And I'm Angela Acker. I'm glad to be a part of this wonderful, wonderful summit. So who has questions for us?
Excellent.
Okay. So first, Angela and Jed, I want to thank you both so much for being here, and Joff also for your presentations. They've been really amazing and incredibly helpful. So I wanted to ask just a very, very practical question. So if I wanted to write a letter to the editor to the newspaper to raise awareness about the need to change the narrative, and let's say I saw something in the paper about, I don't know, that there was a dispute about building affordable housing in Watertown. And I wanted to write something that changed the narrative away from a scarcity kind of worldview to a richness worldview. what would be some of the messages that I should use in a well-crafted letter to the editor?
Yeah, thanks for that. Is that Rabbi Bonnie? I can't see
Right, so
people.
that was me, yeah.
Okay, yeah, I know your voice so well. So first I would say pull up that transformed narrative draft. Um, because what you can do is, and I know that this is what some of our communications folks over at Human Impact Partners do. They look at the draft first and just absorb it before they start their, like, communications points, or um, even if it's like a letter to the editor. And so then you think about, what are you really trying to lift up and what do you want? And so what do you want is, you want everyone to be able to have accessible, affordable housing. It shouldn't be that just because you are educated, or just because you have the funds, that you get to have the win of housing. But regardless of your status, regardless of who you are, you deserve the right to have housing that is free of lead, housing that you can afford, housing where you don't have to choose between a building and food. Um, a place where you don't have to just think about where your next check will come from to pay the rent, but somewhere that you have a roof over your head for your child that is safe. And so you want to think through those messages that highlight the things of what you want, and not just you know, uplift the doom and gloom, because we often do that. We often say, the housing market right now absolutely sucks. And the price and the prices are high and they're gouging, and we just stick to the doom and gloom, but we never ever put a picture of what we really want and what it could look like. And so we want to paint that picture and use the messages of, what does it look like to have housing where everyone can afford it, everyone can access it, and it doesn't break the bank to do so.
I actually think it makes a lot more sense, or I find when I'm in a situation where I'm trying to redefine the narrative, that I get more buy-in, or it resonates better with people, to use that, the language that I heard some of you presenting before about, we all do better when we all do better. The whole idea of lifting up the entire community as a goal, because I hate to say this, I hate to disagree, but whenever you frame anything in terms of a right, you immediately hit a wall about that whole concept of individual rights and individual responsibilities, and you feed right into that zero-sum game analogy, and narrative. And so it seems to me that the best way to sell a new narrative is that whole idea. I think the Minnesota example is in some ways a brilliant idea of why a living wage raises up everyone in the community, and that it hurts no one to make sure that everyone has a clean, warm, safe place to live. And I think also, especially focusing on the needs of children, is a way that I think you can often get buy-in in the community, because nobody wants children to go hungry. It's real easy to, blame a single mom or blame an unemployed parent, but at the end of the day, most people really don't want children to be punished for those things. And so, to me, it's that community raising the tide for the whole community that works, instead of putting it in the terms of people having rights to certain things.
And that's absolutely true. But I also, oh, and Jeff put something in the comment, which I don't think anybody can else see the chat. If you can say your name so we know who we're talking to.
Yeah, that's
We can't
Monica,
see you.
Reverend Monica.
Awesome, thank you. But yeah, that's a great point, Reverend Monica, because you really have to think through who you're talking to, and who your audience is to know, even understand what makes them tick. And so I can say to you that everyone has a right to housing. But would I say that to a politician? Maybe not. Would I say that to, um, a community member that I do not know? Maybe not. But I need to know what makes them tick. That requires some discussions, that requires understanding, again, who you're talking to and your audience around that, because those messages may change. Those messages should be changed. They should translate over. But thinking about, again, starting from the narrative that you want to uplift and the world that you want to uplift first, and then driving towards those messages and find.
For being here. We appreciate it.
Thank you.
All right.